Good morning and welcome to the LMC's Practice Manager Conference. I'm sorry I can't be with you today, but due to commitments nationally related to the future of general practice and the crisis that we all face, I have to be at a meeting all day, so hence my recording. As some of you may know, my practice manager has recently left, and therefore I have spent some time assisting our deputy practice manager in running the practice. Some practice managers have interpreted this that I believe you can run a practice on half a day a week. I can assure you that absolutely is not the case. Dealing with the staff and the doctors is an absolute nightmare, as I'm sure most of you will agree. Therefore, please be clear, I'm assisting my deputy practice manager. I am not acting as the practice manager. We all face many challenges. It's clear that we've got rising workload, the population's growing, it's getting older, more patients have got long-term conditions, the resources that are available to practice don't keep pace with the workload. The system in many aspects is in meltdown, not just in secondary care but in primary care as well. On top of that, we have a recruitment and retention crisis, and again not only of GPs but also of practice managers. So what does all this mean? Currently it means that general practice isn't a great place to work. It's worth looking at what the government's agenda is, and the government is looking for the development of out-of-hospital care. 50% of the budget currently is spent on inpatient or outpatient care in a hospital setting. General practice gets about 8%, community services anywhere between 15 to 20%. With the growth in hospital-based care, we cannot afford to carry on as we are, so we need to develop strong and coordinated out-of-hospital care. Reverse the trend of spend in secondary care and the growth in that sector. Also, it's clear whatever happens after the election in May, that the integration of health and social care will become a major issue in terms of moving it on from talking about it to making it happen. For all this to occur, we need innovation, and we need innovation at a local level, not just national innovation being imposed on us. I'm sure many of you have read the 5-year forward plan, and if you haven't, it's worth looking at. And within that, there are some key features which I've read which make me believe that there is an agenda about developing primary care and particularly general practice. It clearly states in the document that it recognises that general practice is under strain, that recruitment is not keeping pace with the demand that is required, that general practice has fallen from about 10% in terms of proportion of the budget spent on care to about 7.8%. That trend needs to be reversed. That we need to shift funding from secondary care into community-based care. And over the next 5 years, there's a commitment to increase the funding in general practice and the wider primary care. We also need to train more GPs to be able to fill the gap that is being left. But as all of us know, there is no point just training more and more GPs if general practice isn't made a better place to work, and that we can retain GPs at both ends of the spectrum, the new GPs coming in and the GPs who are coming towards the end of their career. So what do we do now? Well, what we know is that the 5-year forward plan values the registered list. We need to recruit new GPs, retain the older ones, and part of the out-of-hospital care is how do we deliver that at scale? It isn't possible to deliver all that we need to at individual practice level. We're going to move towards something called place-based commissioning, which I'll describe in a bit more detail. And also that there will be integration between the GPs and community services. But there is still a question about how we integrate with voluntary sector and social care. So turning to the registered list, this is the cornerstone, and it has been for many years, of British general practice. 99% of the population are registered with a practice, and it's the reason that's given for the NHS being the most cost-effective healthcare system in the Western world. Those aren't my words, they're done by the Commonwealth Fund in America, who've assessed the 11 OECD countries. So we are come first or second in most of the criteria that they look at. What we also need to look at with registered list is how we look at continuity of care versus looking at a wider population. In terms of recruiting new GPs, we have a negative culture at the moment. So there is a question, why would any young GP want to join us when people feel negative about the current situation, let alone the future? The workload is a disincentive. The risk that we run as individuals in terms of employing staff, property ownership, holding a lease that may go on for 20 years. There is an issue as the population changes in terms of the demographics of GPs, that more and more are female, up to 70% are now currently female. That gives us some advantages, but it also challenges us to look at part-time working. And the 30% that are male, many of them are also working part-time doing portfolio type careers. So what does working at scale really mean? This is looking at out of hospital care. We need to retain practice identity. That's really important to patients and to GPs. So you can move towards a super practice of 50, 60,000, or you could work in a federation or network where that may cover, some of our federations go up to 200,000. It's also about developing general practice as a provider organisation at scale, so that when we have discussions about winter pressures or new services, that general practice has some influence and some power and the ability to provide those services at greater scale over a larger population. Gives us a place at the table and enables us to get some of those contracts that will be required in out-of-hospital care. Is this different from traditional general practice? Yes, it is. Doesn't mean that your practice, you need to get people to leave on a Thursday to work for the larger federation. But what it does mean is we need to be part of a larger organisation when we're looking at the future of healthcare. Some of you may have heard the term place-based commissioning. What this is saying, it goes back almost 10 to 15 years to total purchasing pilot. And what it's saying is that if you look at a town or a part of a city, if you took a holistic view of the healthcare needs of that population, could you provide it in a better way than we do now? And that's looking at things to do with primary care, both community and general practice, social care, the voluntary sector, and stuff that's done in outpatients or in hospital based at the moment, the ambulatory type care. So if you were given a budget for your town or your part of your city, could you spend that money more effectively than if we use the current silo funding going into general practice, community and tertiary or secondary care and community? So what does all this mean? The 5-year forward plan looks at new models of care which are being developed, and there are a list of them which include secondary care and primary care working more closely together, called the PACS model, or the multi-specialty community provider, the MCP. And there are a number of other networks where we could look at urgent care, maternity, etc. The one that is most popular and is being discussed at the moment are the MCP models. There's recently been bids put forward to look at developing these models called Vanguard bids. That we're looking to get 8 to 10 of these sites across the country to start in the summer to explore and give structures which then could be adapted around the country. Somewhat to people's surprise, there appears to be in excess of 100 of these bids, closer to 200, and nearly half the country is covered with bids. So there is quite a lot of enthusiasm to look at new models of care to deliver patient-based services at scale, building on the strengths of general practice, but working with community hospitals in a way which hasn't happened before, to break those barriers down and really essentially develop what would be called an accountable care organisation. So one of the questions I've been asked is, how do we become part of one of these MCPs? Does that mean we give up our practice autonomy? Do we become part of a larger organisation? Well, there are 3 ways you can really do it. One is your federation could be working collaboratively with a community provider, a hospital, and you could do it as a loose arrangement. You could do it within a network where you become part of that organisation, but you remain independently. We will be developing some single organisations, which could be community interest companies or social enterprises, and for those, practices could be part of, but wouldn't be totally subsumed by them. They would work independently in general practice as they do now. But whereas we try and work with community services and try and develop better services by working collaboratively, this enables you to develop services in a much more effective way, because essentially you become part of a single organisation. So what's the clear direction of travel? Well, we build on registered populations. We look at personalised, population-based care. Place-based commissioning will become more important, particularly if budgets are devolved to areas to spend in a different way. That will absolutely require us to work at scale, integrate with community services, And to do that, we need strong GP leadership. The new models may attract new GPs and retain existing ones. Making general practice a better place to work, many of the younger GPs are looking for much more portfolio type careers, so that they can spend 2 or 3 days a week doing general practice and 1 day a week doing education, research, or a clinical specialty that they are interested in. So working towards that will be better for our futures in terms of being able to get new GPs to join us, and may provide some interest for older GPs who might stay on to do different roles than they currently do. Why should we do this? Well, we all want better services for our patients. We want general practice to be more sustainable. By doing this, that's where new money looking at out-of-hospital care will come from, and that will help wrap services around the patient and support practices. We want new resources and reduce the silo working, and actually giving us greater control and integration with the community services, the holy grail many of us have been trying to achieve for a number of years. Is this the end of partnerships? No, but alternative models are going to evolve. If we look 5 years' time, I predict that there will still be many practices who work at partnership level, that may be part of a larger community interest company, but there will be some practices who will be run by an acute trust or will be part of an accountable care organisation and will be employed by that accountable care organisation. What we want to ensure is that there is choice for practices to do what's best for their patients and for themselves in the future. Are we prepared to change? And I think one of the questions is, do we lead this or are we led? And who should lead out of hospital care? When I ask people, should it be the hospital? Should the private sector do it? Should the local authority do it? Or should it be led by general practice? Most people I talk to believe general practice are the ones who should lead out of hospital care. You won't be surprised that I'm very optimistic about the future. I think we're in a really difficult place at the moment, and one could say that things could only get better. But I think there are opportunities coming along which will happen over the next 6 to 12 months, which will mean we can turn the current problems around and find new solutions to the challenges we all face. If we can encourage younger GPs to come and join us, we look at different skill mix, we get new resources, we can once again make general practice a really fantastic place to work and become the first choice for doctors who are going through the system, rather than the current view, which is, why would I want to be a GP? I'd sooner work in hospital-based care. I hope you enjoy the rest of the day, and I'm sorry I can't be with you. I'd like to introduce our next speaker, who's Carol Cusack, who probably isn't known to many of you because she's not very visible. Well, she's certainly not visible today because she is actually standing at the lectern, but you probably can't see her because she isn't tall enough to look over the lectern. So we'll get a platform to put beneath her so that you'll be able to see her and hear what she's got to say, as I'm sure she's got some very interesting and worthwhile things to say to you.
I'd like to introduce our next speaker, who's Carol Cusack, who probably isn't known to many of you because she's not very visible. But she's certainly not visible today because she is actually standing at the lectern, but you probably can't see her because she isn't tall enough to look over the lectern. So we'll get a platform to put beneath her so that you'll be able to see her and hear what she's got to say, as I'm sure she's got some very interesting and worthwhile things to say to you.